All right. Well, you know what? Let's get started. And if there's anything that Dalton needs to come back for, um, I'll pause briefly. Let me share some slides that I made for this talk. Um, and hopefully, let me just. Hopefully, there's no more technical glitches, especially on my end. But um, we'll see. Um, I'll just kind of finish up the introduction from Dalton there. My name's Alexander Coltoff. I'm at the Medical University of South Carolina right now in Charleston, South Carolina. I primarily treat chronic myeloproliferative neoplasms like PV, ET, and myelofibrosis, but I also treat acute leukemias and some other kind of variable conditions that may or may not become acute leukemia. Um, so it's nice to kind of meet everyone today. Dalton asked me to, give a kind of little overview of uh, kind of MPNs and genetics, which I think um, is a pretty broad topic, but I'll try and kind of focus on the take-home messages, I guess. And I think with a talk like this, it's invariably going to be a little bit maybe more scientific lingo and parlance than other talks that HealthTree might sponsor. But I've tried my best to kind of make it accessible. And if there's any questions during the presentation where things are unclear, please just unmute and ask me. Otherwise, I'll see the chat at the end, but I might not get to it until the talk is over. So welcome, welcome any interruptions. Um, all right, so kind of overview what we'll talk about. Um, First of all, what do we mean by genetic mutations exactly in MPNs? How do we test for those genetic mutations? We'll talk a little bit about the difference between driver mutations and co-mutations. I think, the emphasis on this talk is really about co-mutations over driver mutations, since driver mutations are expounded upon in other settings and frequently the kind of the stars of talks. But I still think it's important that we touch briefly on what driver mutations are and how they kind of factor into the kind of treatment of MPNs. We'll talk about what the different kind of results for genetic testing might have on your treatments and kind of your recommendations that your physician discusses with you. And then, how do treatments of MPNs differ based on those results? And what might the future hold for kind of personalized medicine approaches in this space? Very kind of cursory overview of the conditions we'll talk about today, and this is probably more basic than we need to get into, but we have ET, PV, and myelofibrosis as our three kind of classic MPNs. There's other MPNs when you get down to the nitty-gritty criteria outlined by the World Health Organization or another group called the ICC, but when we talk about, in medical vernacular MPNs, we're talking about ET, PV, and MF. So ET or essential thrombocythemia characterized by a high platelet count, typically Polycythemia Vera or PV, characterized by a high red blood cell count, but frequently high platelet count and also a high white blood cell count, depending on the specific case of PV. Both of these kind of less aggressive MPNs can turn into myelofibrosis or MF over time. We call that secondary MF. Um, or myelofibrosis can present out of nowhere. We call that de novo myelofibrosis or primary myelofibrosis. Um, and although there are some subtle nuances of secondary versus primary MF, in general they're treated fairly similarly. And the same kind of mutational drivers or co-mutational workup is done for both primary and secondary cases of myelofibrosis. Um, so, genetics and cancer really go hand in hand. I remember when I was a resident or an intern, one of the physicians who I was working with asked me a very simple question, kind of what is cancer? And I thought I knew because I wanted to go into oncology, and so I said it was a disordered growth of cells that should normally not be growing as much as they should be, and he said that was partially right, but really what cancer is a disordered growth of cells caused by some mutation or DNA change. And so, those are really kind of the hallmarks of cancer, right? Is yes, we have some cells that are growing kind of out of proportion to what they normally do. And with solid cancers or solid tumor cancers like breast cancer, colon cancer, lung cancer, I think those are oftentimes easier to conceptualize because you can see a physical mass that's growing in size. And so you can kind of tell that, these cells in the body are not growing at their normal rate. With blood cancers, it's a little bit harder sometimes to conceptualize that because your blood itself isn't necessarily expanding beyond what you can see. But blood cancers all kind of share this disordered growth of some blood cells, typically in the bone marrow, but sometimes in the blood itself, like with MPNs. And the second kind of key component of, the cancer diagnosis is that there's some mutation underlying that abnormal growth. And when we talk about DNA mutations, we can kind of characterize them broadly into either germline or somatic mutations. Germline mutations are present typically in every cell or in half the cells of your body. And germline mutations are DNA mutations that you inherited from your mother or father. Um, and so because these were in either either the egg cell or the sperm cell that gave rise to the embryo that then formed you, those mutations are then in like half or all of your cells, right? Hopefully that makes sense because they were there at the very start, and so every cell that came from that cell will have that mutation. In general, germline mutations can predispose to cancer, and some common ones that are in kind of the zeitgeist are things like the BRCA mutation, which predisposes to breast cancer, or mutations in some DNA repair genes that can predispose to things like Lynch syndrome. But typically, by themselves, germline mutations don't necessarily cause cancer all the time. What really causes cancer um, more frequently, and especially in the kind of context of MPNs, are somatic mutations. So somatic mutations are DNA mutations that occurred at some point during someone's life. They weren't there at birth. They weren't there when an egg was fertilized by a sperm cell. They developed sometime after the embryo was formed, and they might develop even before birth, while kind of a fetus or embryo is still developing. But they're not there in 50% or 100% of the cells in the body. They're only there in a certain portion of those cells because they happened, after the kind of initial embryonic development. And for blood cancers, those somatic mutations are usually isolated to blood cells or bone marrow cells. And the kind of common mutations that we'll talk about, like JAK2, like CALR, like MPL, and like the co-mutations that matter for MPNs, for the most part, are all somatic mutations. So you might see that, like that term or those terms of germline or somatic mutations on your medical records, or you might hear them brought up by your physician in clinic. And that's what we mean by somatic versus germline. When we talk about mutations, we talk about kind of genetic changes, right? And so what is DNA? What are genetic changes? So in the most basic sense, DNA is kind of the blueprint for your body, your body. Oftentimes I'll equate kind of cells kind of copying themselves and mutations to an architect following a blueprint, and that architect might have to copy that blueprint, you know, um, when they just start a new product, if they need to give the blueprint to, another person of their team, so they can also follow this kind of design. this design plan and specifics for constructing a building or constructing a new wing of a hospital, whatever it is. Your genetic code essentially tells your body what proteins to make, what structures to make, how to make them, and it's the instruction manual for making new cells in your body. DNA is confined to this area of the cell called the nucleus. In the nucleus, you have these kind of large pieces of DNA called chromosomes. You inherit 23 chromosomes from each parent, so you have 46 in total. And within each chromosome are kind of thousands of genes, genes being small pieces of DNA. And these genes really encode instructions for proteins, and proteins are what are kind of the building blocks for your body. And so you can imagine, some DNA mutation then causes a protein to be made incorrectly, and that protein to be made incorrectly then causes some issue with how your body normally functions. There's different types of mutations, right? Another kind of confusing aspect of talking about mutations is that not all mutations are created the same. And I think a helpful analogy for thinking about mutations is thinking about your genetic code like books. So I use kind of the example of blueprints before. You can also think about, this information being contained in just like volumes and volumes of books. And these books essentially tell your body kind of how to make proteins, what proteins to make, when to make them. And so there's different ways that you can have genetic changes, right? One way to lose or gain genetic information is to have chromosome changes. So chromosomes, like I said, are kind of large pieces of DNA that have coalesced into these kind of um, expected chromosome pairs. And you can, lose whole copies of chromosomes or parts of chromosomes. So you can see here, you can sometimes gain chromosomes. So, for example, this person's um, genetic testing has shown a third copy of chromosome 21. This results in something called Down syndrome. Um, or sometimes you can lose chromosomes, right? So this person has lost one of their seventh chromosomes. So they only have one instead of two, like all their other chromosome pairs. And I would equate this to kind of like losing chapters of a book. So these are these are changes that eliminate large pieces of DNA, and those chromosomes have many genes on them, not just one gene that's kind of altered. You can have kind of swaps of chromosomes. So parts of these chromosomes can change places. A very common example is part of the ninth chromosome and part of the 22nd chromosome switching places. That results in something called the Philadelphia chromosome, and that's the genetic mutation that causes CML or chronic myeloid leukemia. And I would kind of equate that to swapping the place of chapters in a book. So even though we're not losing any genetic information, you can imagine if you're reading a book and the last chapter is switched places with the fifth chapter, the book's not going to make much sense. And so that's another way that changing genetic information can lead to issues with cells and developing cancer. And then there's kind of changing words or paragraphs in the book. And this is kind of equates to kind of changing very small pieces of DNA affecting just one gene at a time, right? And so you can either switch part of your genetic code. So DNA is composed of these four different markers called um, uh, T, A, C, and G, or thymidine, cytosine, adenosine, and guanine. And so just switching one thymine or thymidine for one cytosine, you have billions and billions of these, markers. But switching just one can lead to a mutation in the genetic code for a single gene, and then that gene might have a mutation. Um, and so this is what happens with a lot of our driver mutate or some of our driver mutations in MPNs. So for example, the JAK2 mutation is, caused by a point mutation. Um, but you can have, just some of these building blocks changed. You could have some of these building blocks added, like insertions. You could have some of these building blocks deleted. But these are happening on a very, very, very small level compared to these larger chromosome changes here. So I know it's very much in the weeds, and that's probably a little bit more detail than you need to know, but That's what we're looking for when we look for genetic changes in cancer. We're not just looking for one type of genetic mutation. We're looking for, are there large chromosome changes? Are there small chromosome changes? Do chromosomes switch places? Are chromosomes all there, but the DNA on the chromosomes is a little bit different? Um, it's really varied in terms of what we mean by kind of uh, uh, genetic mutations. Um, I see two questions right now, which I think is probably a good place to stop um, for a second. The most recent question, is a missense mutation the same as an inversion? Um, which is a great question. It's not the same thing. So if we see, um, uh, sorry, I don't know where my, huh. um, uh, for some reason that little kind of depiction of different types of mutations there at the bottom right went away. But missense mutations are essentially when you have a different DNA base added here. So, like for this example, instead of a T, you have a C, and that causes essentially the protein to be made incorrectly. So, a missense mutation is really more of like a low-level mutation that results from something like a point mutation or an insertion or deletion, but those are kind of like low-level mutations. An inversion is more like what's shown here, where you have large amounts of chromosomes that switch places with each other. Um, and so they both can cause cancer, but they're just not the same on a genetic level. And then the other question that came in was, what is masked PV? It's a little bit out of the context of the talk today, but I do want to answer it, so I'll be brief. But masked PV is essentially a situation where someone likely meets the criteria for polycythemia vera, but may be diagnosed erroneously as having ET or another condition because of some other confounding factor that lowers hemoglobin or prevents the accurate kind of uh, recognition of an elevated red blood cell count. And so that could be things like iron deficiency in menstruating women. It could be iron deficiency due to another cause, but it's essentially PV that is a little bit harder to diagnose, but not necessarily. But masked PV doesn't result from any different mutation versus normal PV. So I'll bring it back to the concept of mutations that way. Um, Okay. How do we test for mutations? Again, I think this is important to know about as patients. You won't be doing these tests yourselves, but this is things that, these are things happening behind the scenes. It may be possible to check for chromosome changes or smaller DNA mutations like missense mutations or point mutations on blood tests. But bone marrow biopsies are really kind of the standard of care for these tests, and that's for a number of different reasons. They, have higher accuracy probably than testing blood for these mutations. There's an increased sensitivity when you use bone marrow for these tests, so you can detect genetic mutations that are there at a lower amount than you would be able to detect from the blood. You can look for additional information when you're doing a bone marrow biopsy. So you can look at the appearance of the bone marrow. You can look for the presence of blasts or young white blood cells that might signal a higher risk of developing leukemia. And you just get more information when you do a bone marrow biopsy versus a blood test. And then there's also a difficult aspect of performing some of these genetic tests on the blood versus the bone marrow biopsy. So you really need to do the bone marrow for the full range of genetic testing that we have available to us nowadays. Um, if the bone marrow biopsy is performed, then the majority of the genetic testing will be done on what's called the aspirate, which is kind of the liquid part of the bone marrow. Essentially, your bone marrow has some kind of blood floating through it, similar to how your veins and arteries have blood flowing through it. And that's really where we can get a lot of the genetic testing that we do for MPNs. And then it's important to note too, and I tell people this a lot when I see them in clinic, is that a delay in hearing from your doctor about the results of your bone marrow testing is not a sign that things are bad or that things have gone awry. These genetic tests can just take a while for pathologists to do. if some of these genetic tests are being sent out to reference laboratories or larger laboratories like the Mayo Clinic or Johns
Mm-hmm.
Hopkins, et cetera, then there might just be a natural delay in getting those results. But um, I would wait at least, for kind of 2 or 3 weeks to get the full complement of testing back, um, uh, before, getting worried that something has gone wrong. Um, there's a question here. If you tested positive for Cal on your blood, do you still recommend a bone marrow test? That's a great question too. So CALR is one of these kind of driver mutations that can really cause an MPN versus modify it. Um, uh, I think it depends on the situation, but I still do in most cases. The reason is that, a CALR mutation can be seen in different MPNs, right? It can be seen in pre-fibrotic myelofibrosis, it can be seen in myelofibrosis, it can be seen in ET, and sometimes bone marrow biopsies are the only way to distinguish between those three entities. And then even though you caught the CALR mutation in the blood, there might be other mutations that you didn't catch. There might be chromosome changes that you can't test for in the blood. And so, I don't think just documenting the presence or absence of a driver mutation in the blood is sufficient in all cases to forego a bone marrow biopsy. But it is a case-by-case basis, and there might be reasons for deferring or pursuing a bone marrow biopsy that your physician has in mind that he or she can discuss with you. Does a bone marrow biopsy have to be done regularly over time or only once? Another great question. Um, in general, I recommend a bone marrow biopsy for everyone I see with a new diagnosis of MPN to confirm their diagnosis and look for those things I was talking about, like chromosome changes, like signs of a higher risk for developing myelofibrosis or leukemia. After that first bone marrow biopsy is done, I don't generally recommend another one unless there is a concern based on blood work or symptoms that the MPN is progressing. So either ET-PV is turning into myelofibrosis or myelofibrosis may be turning into leukemia. Um, and that's really kind of a nuanced discussion with your physician based on, like I said, how you're feeling, symptoms, your blood work. But it's not something that I necessarily recommend for everyone at regular intervals. I think it's very much a personalized choice. I didn't plan on spending as much time as I did on the nitty-gritties of the different kind of genetic mutations, what they mean. So I might skip this slide. This is just kind of highlighting what these tests look like in the lab. But let's move on to kind of like what we're talking about here in terms of driver versus co-mutations. So when we are talking about MPNs, we are talking about mutations in two buckets, right? We have driver mutations, and these refer to the canonical driver mutations of JAK2, CALR, or MPL. And we call these driver mutations because these mutations are sufficient by themselves to cause an MPN. Um, and their presence or absence can really define what the MPN looks like and how it acts. So for PV, the driver mutation is almost invariably JAK2. You can see here, in this little kind of pie chart, 99% of patients with PV will either have a JAK2 mutation in the V617F codon, or a JAK2 exon 12 mutation. And again, with a basis of, our kind of our science class before, we can kind of point to JAK2 V617F being a point mutation. So for JAK2 V617F, that is a single point mutation, right, where some codon went to another codon, and just one change in a chromosome full of billions of these sequences led to the JAK2 mutation. The CALR mutation is seen in patients both with ET and myelofibrosis, about 30% of each. I think this 15% is a little bit low in my experience for ET. Um, and the CALR mutation, again, results from kind of low-level DNA changes. None of these mutations are due to kind of large chromosome changes. Um, and then the MPL mutation is the least common driver mutation of the three. It occurs in about 5 to 10% of patients with ET or myelofibrosis. I got a chat there. I just Sometimes I know how to get the chat up and sometimes I don't. Let me, um, oh, here we go. What does it mean if your alleles are doubled in JAK2? Um, Uh, I'm not quite sure what alleles being doubled. So, so when we talk about you might have seen the term alleles before or heard the term alleles. Alleles just refers to each gene copy that you have. So, again, I don't want to get too into the weeds here, I guess, but you can think about these chromosomes, right? Like I said, having thousands of different genes on them each. And so you have two copies of each gene, right? So for example, the JAK2 gene is located on chromosome 9. Um, and so, um, and so somewhere on this large swath of DNA, there's the JAK2 gene hidden somewhere here. And so you have one JAK2 gene from mom and one JAK2 gene from dad. And so, everyone has two alleles of each gene. Um, and so that's a normal scenario. Sometimes you might lose an allele if you lose, let's say, one of your chromosome nines. Um, uh, but um, but in general, everyone should have two alleles. Um, I will say maybe your question might be getting at sometimes we refer to mutations as either, biallelic or monoallelic, meaning does a mutation affect both copies of the gene or does it affect just one copy of the gene? And there are certain clues in the nuances of the genetic testing that can tell us, does the genetic mutation you have affect both copies of the gene, or do you have one gene that's normal and then one gene that's mutated? And sometimes that's what we mean by biallelic versus monoallelic. Um, these driver mutations for MPNs, even though there's three different ones, they all really result in the same kind of abnormal function, right? And so you can see all of these um, all of these mutations, JAK2, MPL, and CalR, all affect this kind of receptor. And these receptors are present on the surface of your cells. So inside here is your cell, outside here is, your blood or whatever is kind of exposed to the cell. And cells get signals all the time from the blood um, to tell them to do certain things, right? These are kind of like, I don't know, telephones for the cell. The cell gets a call from the outside through some signaling, and it says, hey, make more of yourself, or hey, start making this protein, or hey, now's the time to retire, stop making proteins, etc. And so no matter what happens, either JAK2 gets mutated, CalR gets mutated, MPL gets mutated, they all result in this kind of receptor telling the cell to make more of itself and to make more blood cells. And that is why these mutations are known as driver mutations, because they all result in the same downstream effect, which is this blood cell getting a signal to make more of itself. Normally, these proteins, JAK2, CalR, and MPL, turn on and off whenever cells need to make more of themselves or should stop making more of themselves. And that's what kind of keeps the homeostasis in your body going. But with these mutations, they unfortunately don't have that homeostasis, and they make more of themselves when they shouldn't. Those are the driver mutations. There are probably 20,000 or 30,000 genes in the body that play a real role in our development and functioning. There's about 50 or 60 genes that we kind of know are commonly mutated in people with MPNs. And in general, we call these genetic mutations co-mutations. So not every genetic mutation is a co-mutation, I would say. We refer to co-mutations in genes that we know have some effect on how cells function or how they divide. And so this is just a very kind of small sample of what those genes might be. Every gene is essentially kind of a mix of letters and numbers. And you can see some of these co-mutations are there more commonly or less commonly in MPNs. Some of the more common ones are things like TET2, ASXL1, and then some of the less common ones are things like P53 or SRSF2, SF3B1, but there's a whole host of these co-mutations. So, like I said, co-mutations typically involve genes that are responsible for other cellular functions, still affect kind of how blood cells divide or how long they live or how active or not active they are, but they're not necessarily kind of part of that signaling cascade I showed before with JAK2, CALR, and MPL. And typically, these mutations aren't enough to cause MPNs by themselves, but they may modify how the MPN presents, how it responds to treatment, and especially the risk of it becoming either myelofibrosis or leukemia, depending on kind of where you're starting out from. So, why do these mutations matter, both driver mutations and co-mutations? Let's talk about how I incorporate driver mutations and co-mutations into my management for each of these conditions. So for PV, it's kind of simple, right? I don't really incorporate driver mutations so much into my treatment because everyone has the same driver mutation for the most part, which is the JAK2. Um, there are two different ways that JAK2 gets kind of altered or mutated in PV. The vast majority of people have what's known as the JAK2 V617F mutation, um, which also is the mutation seen in people with myelofibrosis and ET. A very small amount of people with PV will have a JAK2 exon 12 mutation, which is a different part of the JAK2 protein that's changed. And they both have a similar presentation, but I will say, JAK2 exon 12 mutations typically occur in younger people, and typically they result in a more isolated increase in the red blood cell count, as opposed to the V617F mutation, which can result in increases in all three cell lines: red blood cells, white blood cells, and platelets. But I do treat them fairly similarly. How about ET? So ET is a little bit more varied, right? So ET, like I said, approximately 60% of people will have the JAK2 V617F mutation, but approximately a quarter of patients will have the CALR mutation, and then approximately 5 or 10% of people will have an MPL mutation. And the driver mutations do impart different characteristics on kind of what the disease looks like. So, JAK2 mutations are typically associated with higher rates of blood clots or thrombosis, and they're typically associated with more moderate increases in platelet counts. Versus CALR mutations typically result in lower rates of blood clots compared to JAK2 mutations. They're more associated with severe increases in platelet counts, and they typically occur in younger people compared to the JAK2 mutation. When we talk about kind of future risk for these driver mutations, I typically think of JAK2 having a lower rate of transformation to myelofibrosis and CALR having a higher rate of transformation to myelofibrosis. Um, None of these, scenarios are impossible with either mutation. So just because you have a CALR mutation doesn't mean you won't have a blood clot. And just because you have a JAK2 mutation doesn't mean you won't have progression to myelofibrosis, but these are kind of just general guidelines. And then MPL mutations are rare, and so we don't know as much about them as we do for these other two. But I do think about them being more similar to JAK2 mutations. So a slightly higher rate of thrombosis or blood clots and a lower rate of transformation to myelofibrosis. But none of these things are set in stone by any means. How do I incorporate this into management? Well, as you can see, we just talked about this. In terms of thrombotic events, we can see the cumulative incidence here increasing over time with JAK2 mutant ET compared to CALR mutant ET. It almost, in some cases, reaches the kind of rate of blood clots for patients with PV, which is generally thought to be a higher risk for blood clots. In general, people with JAK2 mutant essential thrombocythemia have about a 2 to 3% chance per year of having a blood clot, compared to a person with CALR mutant ET, which has about a 1% chance per year of having a blood clot. We can see kind of same thing but flipped for myelofibrosis. We have a higher rate here of CALR mutant ET turning to myelofibrosis versus JAK2. And these differences are incorporated into a lot of the kind of standard scoring systems that physicians use to determine what the best treatment for patients are. So the most common one that's used is called the IPSET, score, which is the International Prognostic Scoring System for ET. Um, and there's a thrombosis score that takes into account the history of any blood clots, the presence or absence of cardiovascular risk factors like high blood pressure, diabetes, or active cigarette smoke, or the JAK2 mutation. And so you can see that the presence or absence of this JAK2 mutation can kind of modulate someone's risk score for thrombosis. And someone with a low annual risk of blood clots is treated differently than someone with a high annual risk of blood clots. And so I don't look at JAK2 mutations in isolation or in a vacuum, but I will kind of take them into account in addition with everything else. And so if I have, let's say, a 65-year-old patient who's otherwise in great health and has no kind of cardiovascular risk factors, has no history of thrombosis, but does have a JAK2 mutation, I will be more likely to recommend kind of hydroxyurea or some other therapies versus an older person, let's say, without a JAK2 mutation, without any cardiovascular risk factors, etc. But, each of these things cannot be taken into account by themselves, right? And sometimes, even if people don't quite fall into these categories, if there's risk factors that are not included in this kind of small number of risk factors here that I think kind of change someone's chance of having a blood clot, then I will kind of treat them differently. How do I incorporate co-mutations into MPN management is a different story, and this is a little bit more confusing. So the kind of real answer is that we don't typically incorporate co-mutations into PV and ET management. And I think a main kind of reason for this is that people with ET and PV, do relatively well, right? I mean, compared to other blood cancers, like acute leukemia, let's say, or high risk multiple myeloma, where we have the ability to detect differences in treatments um, because those differences show themselves quickly. When we're talking about cancer that, maybe causes a blood clot in 10% of people in 10 years, or maybe ET, where only 5% of people will transform to myelofibrosis or sorry, acute leukemia, it takes a large amount of people in studies, and it takes a long time of follow-up to really detect differences based on things like co-mutations or treatments. And so we don't quite know exactly the kind of risk of each different co-mutation on different aspects of these cancers. That being said, we know a little bit. So this is work primarily from some Italian investigators as well as the Mayo Clinic, where they looked at people with ET or PV, and they looked at co-mutations, and they saw kind of what co-mutations affected the risk of ET or PV turning to leukemia or turning to myelofibrosis. And so these investigators were able to determine that for ET, having an SRSF2, an SF3B1, a U2AF1, or a P53 mutation, or for PV, having an SRSF2 mutation, increased the risk of turning in of their kind of MPN progressing. Um, in actuality, do I use this score for every person that I see with ET or PV? I don't, because we don't quite know what to do with this information once we have it. We don't know if different treatments can mitigate the risk seen here by these mutations. But I do think it's important for, physicians to know about these scoring systems, and I think it's important for people with these MPNs to know about these kind of scoring systems out there. And like I said, nothing, no part of MPN treatment is done in a vacuum. And I think when I see someone with ET, I calculate their IPSS score, I calculate their MIPS ET score, I calculate other scores I don't even discuss here, like the ARTS, the VETS, the AAA score. And you have to use every kind of, you know, tool in your arsenal to kind of give someone a comprehensive kind of risk assessment. But I think just by themselves, we're not quite sure how to incorporate co-mutations into MPN management in 2026. This is just taking a look at the scores derived in this study, and you can see by incorporating the presence or absence of these co-mutations, the investigators were able to kind of create three kind of risk groups of patients, with high risk patients having a kind of worse survival compared to intermediate or low risk patients for both groups. There's been other studies done looking at kind of mutational status, not with CALR, JAK2, or MPL, but co-mutations. And in general, the more co-mutations that you have, kind of the more risk for progression or the more risk for maybe increased mortality we see across these studies. So again, I think it's important for your physicians to test for these co-mutations and to ideally test for these co-mutations on the bone marrow. Once we get them, it's not clear what to do exactly, but I will say to someone's earlier question of do I do routine bone marrows serially to look for changes, or do I tell someone, hey, come back in a year, I'll do another bone marrow? I don't. But studies like this that show that people with two or more co-mutations with ET have about a 50% chance of progression at 8 years. You know, this does inform my decision making somewhat, where if I have a patient with, let's say, four co-mutations, and maybe one of them is a SF3B1, that might be someone who I do kind of break my mold for and recommend a repeat bone marrow biopsy at 5 years, let's say, or 10 years, instead of just watching the blood counts. So again, I think it all goes back to kind of personalizing your treatment as much as possible with the information that we have nowadays about co-mutation status. Um, I'm talking about myelofibrosis. This is where co-mutations and driver mutations have a little bit more kind of weight to them. So similar associations with ET, in that JAK2 carries a higher rate of thrombosis or blood clots, and CALR might carry a higher rate of platelet counts. Um, there's also, sorry, I don't know why that's animated. There's, once we get into myelofibrosis, we have to kind of now distinguish between different types of CALR mutations as well. So some of you, if you have CALR mutations, you might see in your report you have a type 1 versus a type 2 mutation. Um, these are slightly different kind of types of mutations, and they do kind of confer different kind of risks depending on which one you have. So we know for myelofibrosis that the type 1 CALR mutation actually confers a lower chance of developing leukemia and is associated with an improved survival compared to basically every other driver mutation for myelofibrosis. And we'll see how that's incorporated in some scoring systems in a second. Um, for co-mutations with myelofibrosis, this is where there's a little bit more substance than with ET or PV. So, in general, myelofibrosis has more co-mutations than either ET or PV, which follows a general rule of blood cancers that the more mutations you have, the more aggressive your cancer is considered, right? And so we saw that with ET, where the more co-mutations there were, the more risk of developing leukemia or myelofibrosis. And in general, because myelofibrosis is considered a more aggressive or more advanced MPN than ET or PV, it should follow that there's more co-mutations there. As opposed to, ET or PV, where it'd be nice to know the co-mutation status, but we don't need to know it. We really need to know the status of co-mutations in myelofibrosis. And to someone's point earlier, someone's question that they had a CALR mutation, should they get a bone marrow biopsy? I think if you have myelofibrosis, you need to get a bone marrow biopsy. You need to have the best test to look for co-mutations because these do kind of inform how we treat myelofibrosis. Um, and then that kind of goes along with the last point there that driver mutations and co-mutations in myelofibrosis carry an importance because they actually influence treatment decisions as important as do we need to do a bone marrow transplant or not. So this is really where co-mutations come into play. These are kind of a list from the NCCN, which is the National Comprehensive Cancer Network, of the kind of most important co-mutations that we have in myelofibrosis. You can see here in the NCCN, they kind of note this improved survival with CALR type 1, like we talked about before. And then this is a list of the kind of co-mutations to kind of keep in mind when you're looking at your genetic results. And how do we incorporate them, right? So just like for ET, we have those scoring systems to kind of risk stratify people based on their risk of thrombosis or blood clots. We have scoring systems for myelofibrosis that can kind of group people into risk categories for developing leukemia or for having a lower survival. And I'm sure, or I'm hope that if anyone in the audience has myelofibrosis, that you've seen this score in your chart or you've discussed this score with your physician. If not, you really need to have this score calculated as soon as you get diagnosed, because it really does affect how you're treated. And I will say, this is where I give my little public service announcement to always get evaluated at a transplant center if you've been diagnosed with myelofibrosis. I have patients, unfortunately, who, by this scoring system, really should have been evaluated for a transplant early on when they were diagnosed, and they weren't because sometimes general oncologists don't know about these scores. And then when it came time when they finally saw me, they were too old or they were too sick to get a transplant. And that really could have been avoided if they had been referred as soon as they were diagnosed. So I'll kind of put that PSA at this point of the talk, but this is probably the most common scoring system that is used nowadays, especially in academic centers for myelofibrosis. It's called the molecularly inspired prognostic scoring system. Um, and it incorporates not only the kind of um, presence of anemia or high white blood cell count or low platelet count, but you can see that about half of these variables in the scoring system are actually genetic factors, right? So like absence or presence of that type 1 CALR mutation, the presence of one of those high-risk co-mutations, the presence of two or more of those high-risk co-mutations, um, the presence or absence of chromosome changes that are considered high risk. And that's why it's so important to have that information available because, depending on the answer, yes or no, for these variables, it can really affect what kind of risk category you fall into, and then subsequently how your disease is managed. Um, and I tried to highlight that here a little bit. So you can see here, this is a kind of fake patient with no CALR type 1 mutation. So maybe they have a JAK2 mutation or an MPL mutation, but they have no high risk co-mutations. They have no high risk chromosome changes. And so they fall into this intermediate risk category. And generally for intermediate risk myelofibrosis, we sometimes recommend transplant, but we sometimes don't. Sometimes we'll start with JAK inhibitors. It's a little bit more of a nuanced treatment. Here, this is the same patient, except I've changed them to have a CALR type 1 mutation. And so you can see now they fall into a low risk category. And so this is a patient who I would definitely not recommend for transplant. I would even think about not doing a JAK inhibitor if they're not having symptoms or if their spleen is not very big. So, so here, just one change based on a genetic test changed management. Here, I've given them that CALR type 1, or I've given them that maybe like that JAK2 mutation back, and I've given them just one high risk genetic mutation. And you can see now they have a high risk myelofibrosis. And this is someone who I'd recommend for transplant up front if they were young and healthy, or I definitely started JAK inhibitor as soon as I could. So you can see here, even just one high risk co-mutation can dramatically affect someone's treatment and recommendations. That's why it's so important to know about your status for these genes when you get diagnosed. Um, I did want to speak a little bit about triple negative myelofibrosis and what the future might hold uh, for personalized medicine. But I want to make sure I answer questions actually. So let me answer questions. If you have questions, now's a good time to put them in the chat. And then if I have any time at the very end, I'll briefly talk about maybe kind of what the future might hold for personalized medicine. So Someone said they're a parent to a 23-year-old with JAK2 V617F MPN, and they have two germline mutations, as well as a presumably somatic mutation in DMT3A. They're asymptomatic, but feels like they should start interferon since they only meant to stop progression. Can interferon have any impact on reducing mutations outside of JAK2? That is a great question. I had a patient ask me that question in clinic this week, actually. And I think the straightforward answer is that we don't quite know yet, right? Um, the uh, the the largest kind of data that we have for interferons with reducing the JAK2 percentage comes from this European study called the PROUD and the continuation PV studies. Um, and we're talking about a fairly small amount of patients in those studies. And when these co-mutations happen in, let's say, only 5 or 10% of people with PV, we just don't have enough substantial data, I think, to definitively say what happens to co-mutations on interferon. And I think more importantly, if that even matters, right? I mean, if someone's JAK2 mutation is decreasing in frequency, I'm not really too worried about the co-mutations um, overall. But it's a great question. Hopefully, with more data from real world interferon use, we'll know that. Another question that came in is, can co-mutations develop after initial diagnosis? And that's another great question, and they definitely can, and that would be a reason, again, to kind of circle back to, do we repeat bone marrow biopsies after diagnosis? It would be a great reason to interrogate to see if that happened. Um, and in fact, I would say co-mutations are the main way that myelofibrosis or PV and ET, really progress. Um, Especially with myelofibrosis, right? With PV or ET, sometimes they progress to myelofibrosis because the JAK2 or the CALR mutation goes from being in 20% of blood cells to being in 70% of blood cells, and that by itself can cause progression. But sometimes, the progression can happen because someone develops a new ASXL1 mutation, or someone develops an IDH mutation. And especially with myelofibrosis, progression often happens because of those co-mutations. So someone has myelofibrosis and they develop a P53 mutation, and then they develop leukemia, or they develop an IDH mutation and they develop leukemia. So co-mutations can definitely develop after diagnosis, and there's something that is really important to look for when you're repeating bone marrow biopsies. Um, but another great question. Um,
And then Dr. Coltoff, one, thank you for hopping in when my internet crashed there for a little bit. It was nice to hop back in and see that things were running smoothly. I did get a question from a patient as well. They're asking, can you speak to the issues of exposures causing these mutations? Is there much research being done for this? For instance, microplastics, chemicals, etc. Or do you have any pointers as to how they could dig into this, like where to look or things to look up?
yeah, another great question. You know, we don't know as much as we probably should about environmental triggers in general for hematologic cancers or blood cancers. Um, we know that certain environmental, triggers exist, right? Like ionizing radiation, people, exposed to, you know, um, things like Chernobyl or, people exposed to atomic bombs in Hiroshima or Nagasaki in the past, and then obviously more modern examples, like people, with hazardous exposure at their jobs can develop um, cancers. Certain dyes, like toluene dyes, can cause hazardous exposure. First responders, a lot of times, like I'm from New York originally, and so we would see a lot of people after 9/11, first responders, firemen, policemen, who would develop cancers early on. Agent Orange is another kind of environmental exposure that's been linked with some blood cancers, but not all blood cancers. I think for MPNs, because of their relative rarity and because of how long they take to develop, it's oftentimes the kind of difficult to link them to environmental exposures. You know, very interesting study in MPN, something that you guys may have heard about before, is a study that was done maybe 5 or 10 years ago, showing that some people can even develop the JAK2 mutation in utero, right? And so some people with MPNs can develop the initial JAK2 mutation at a very, very low level, 20 or 30 or 40 years before they actually develop a clinical cancer. And so I think it's really hard to kind of retrospectively go back and identify triggers a lot of times for these chronic blood cancers. But it's certainly an area of interest within kind of the MPN community, and hopefully in the future we're able to kind of maybe prevent some of these cancers before they start. Um, and then Dalton, I see another question came in. Is the MPN space seeing more young patients diagnosed, and is the field thinking about this unique group in any different ways? Um, a great question. I think colorectal cancer is obviously in the news a lot nowadays about being diagnosed in younger and younger people. But I think, in my experience, most cancers are being diagnosed in younger people, or maybe that's just anecdotally what I see. But I think, especially for cancers like MPNs that were relatively unknown even 20 years ago, right? I mean, the JAK2 mutation wasn't even discovered more than 21 years ago, and CALR less than 20 years ago. And so I think, naturally, as time goes on and knowledge about these MPNs are disseminated into more and more physicians, not just in specialists, then patients with, let's say a younger person who has a high platelet count or a high red blood cell count, who maybe 15 years ago was just kind of thought of as an oddity, nowadays that primary care doctor might know about ET, they might know about PV, they might even know enough to send for a JAK2 or a CALR test, and they might diagnose them earlier than they normally would be. So I don't know if something's changing, in the water or in the in the general kind of exposure to Americans or people worldwide that's causing, younger MPNs. But I think we're getting better at diagnosing them. And I do think, along with that question, we're also trying to shift our focus more from just treating numbers to really preventing progression and to even kind of getting deep remissions in these cancers, which we really weren't doing with Hydrea or other treatments in the past. And so, I do think that is really the focus of the MPN field in 2026 is, how do we kind of how do we change the disease course, not just change the risk for blood clots or change the risk for high counts. And that does go along too with the topic of this talk, right? Which is that I think in order to change the risk for developing myelofibrosis, to change the risk for developing leukemia, I think we're going to need to target those mutations that we're talking about and really try and lower their percentages and get them gone. So it all goes back to the mutations.
Yeah. And we are about 5 minutes after, so they're happy to have you as long as you
Yeah,
want, Dr.
I'm
Koltov, but I do know that time is
yeah.
precious, so
No, I'm happy to answer questions if they're still coming in. This one looks long, so I'll try and read it quickly to myself. Are there one more examples of serious individuals who are cured or in full remission despite initially having low chance of survival to answer this? Sure. Yes, I mean, I think this question of are there exceptions to the general rule, is, yes, is the short answer, and that's not, an exception for MPNs. I think it's a little bit out of the context of this talk, but I'll give one example. I had a patient I saw, maybe a year or two ago, who was diagnosed with accelerated phase MPNs, which are essentially kind of this in between stage between chronic MPNs and leukemia. And the prognosis for that condition is unfortunately very poor. It's about a year or two. And I was seeing her about 10 years after her diagnosis, and she really hadn't gotten any treatment like chemotherapy in those 10 years. And so, rules are rules because they have exceptions. Or there's, that's the saying, right? And so, yes, there's always exceptions, and there's exceptions in myelofibrosis, in ET, in PV. But in general, I think as physicians, we have to go with the most likely scenario based on each case. And so we do kind of recommend treatment based on the most likely, outcomes for someone using all of their information that we have available. Um, one more question. Okay. Will a single hit TP53 mutation make transplant less likely to be successful? What about paired with other co-mutations like ASXL1 or EZH2? Great question. I was waiting for someone to bring up P53 mutations, honestly. P53 mutations probably, out of all the co-mutations that we discussed, have a special place in the hearts of oncologists because they are really thought of to be the most dangerous co-mutations in most cancers. Um, there's been some controversy with P53 mutations and MPNs. Some studies show that they're bad no matter what. Some studies show that they're only bad if they are kind of biallelic. So this is great. We're nicely tying in an early question at the end of this talk, which was, maybe like what does double JAK2 or double allelic mean? So there's some studies that show that, I think in general, at least what I believe, I think a lot of people believe this. If you have mutations to both of your P53 genes, that's a bad scenario. And that's someone who I'd really recommend for transplant and needs to be treated aggressively. I think whether or not a single mutation with another working P53 gene is as dire a circumstance as we think is debatable. And so I would say it really depends, this question, on other factors. I do think a P53 mutation paired with other two high risk genes like ASXL1 and EZH2 merits a strong transplant consideration. Whether or not those genes affect the success of transplant is debatable. And I think it really goes into the nuances of that P53 mutation. There's data that suggests that not every P53 mutation is created equal. And then it also depends on if that P53 mutation is there in 7% of the gene of the cells or in 70% of the cells, right? There's really some nuance to that single hit P53 scenario, but it is a very, very kind of hot button issue, P53 um, and MPNs. Um, I'll use this breaking questions as a way to wrap up the talk, but please feel free if there's anything that you want to ask, please ask it now. I'll just say two quick things. One, I think we're trying to get more personalized in MPNs, and so there are these kind of drugs in development that target CalR specifically that I'm hoping will be in the clinic in the next 5 or 10 years for people with CalR mutations that specifically kind of target that mutated CalR protein. It's very exciting. And then there's other drugs in development that might target things like IDH1, IDH2, or other kind of co-mutations in an attempt to get kind of therapies more personalized on a case-by-case basis for patients with MPNs. And then just to wrap up, if you guys want some take home messages, it's that driver mutations cause MPNs, and they're almost always exclusively or mutually exclusive. So if you have one of these, you probably don't have another. It's not always the case, but it's usually true. And then co-mutations can modify the risks of the disease, but in general don't cause the disease by itself. Both driver mutations and co-mutations might affect the chance of responding to treatment, um, and they might influence kind of what our treatment decisions are. And then I think targeted therapies based on driver or co-mutation status are really kind of one of the future kind of goals of the field, along with things like disease modification um, and just kind of more personalized medicine. So I really appreciate Dalton HealthTree for having me and allowing me to speak to you guys about this very interesting topic in MPNs. And thanks everyone for staying with me past time and your questions. It really made for a more interesting hour.
That was so great. Incredibly informative and in-depth, but easy to follow along with. So truly, Dr. Koltoff, that went way better than I ever could have expected it to. So that was fantastic. I did have one more question because I know that the audience will be asking me. Um, will your slides be available to those who registered? You
Oh,
can send
sure.
a copy of them to me, and I'm happy to distribute those. But I know I always get questions from people asking if they can get a copy of the slides. So we can coordinate that after the fact. But I just wanted to ask that to see.
Yeah, no, I will send you my slides, and my last slide has my contact information on it. So if anyone has any questions, please feel free. You can always reach out. I can always talk more about this.
Awesome. And as we get ready to hop off here, I just wanted to know of some upcoming webinars that this community might be interested in. So on Tuesday, June 2nd, we have rollout of new financial assistance program for cancer patients, how this can benefit you. And then on Thursday, June 4th, we have the next of our community gather series. These are events that are really geared towards getting MPN patients connected with one another. So this one will be a community gather. How do you decide who to tell about your MPN diagnosis? These events are not recorded out of respect for privacy for those individuals, to try to just create a little bit more welcoming, open environment. So if you are interested in that, please attend live. And then on Monday, June 8th, we have Next Gen MPN Care, highlighting research from Memorial Sloan Kettering with Dr. Rajit Rampal. So a couple of really good events coming up over the next week or two here for the MPN community. And finally, just a big thank you again to Dr. Koltoff for a fantastic presentation and also for managing things when my internet cut out on me. Thank you for everyone. Thank you everyone for bearing with me on that. And thank you everyone for joining us today and spending part of your day with us. I really do appreciate you all. And my contact is up on the screen. Please feel free to get in touch with me if you ever have any questions. I am happy to help you. So I hope everyone has a fantastic rest of your day.
Thank you.